Welcome, everybody. I am so glad to welcome you to the third and final day of the PASC 22 conference. And in keeping with our overall theme of computing and data for all humankind, today we're beginning the day with a very special presentation on the challenges of modern epidemiology. We're grateful to welcome Olivia Kaiser from the University of Geneva to speak with us this morning. She is an SNF professor in epidemiology at the Institute of Global Health at the University of Geneva. She's originally from Basel, where she studied biology, and then she moved to Lausanne, where she worked for the Swiss HIV cohort study. And then in 2016, Olivia joined the University of Bern for her PhD work, focusing on analyzing HIV patients in Africa. After receiving her SNF professorship in 2017, she moved her research group to Geneva, and she incorporates a very interdisciplinary approach to studying her various elements of HIV and COVID-19. So today she'll speak about her group's work in using this interdisciplinary approach to studying epidemiology. So welcome, Olivia.
Thanks very much for the introduction. It's very nice to be back in the hometown. Quite unusual to give a talk, a scientific talk at home. So I'm going to start first to talk about the origins of epidemiology. You see here probably one of the most famous pictures is the cholera outbreak, which happened in London in 1854. You see in red, it's the cholera cases, and in blue, it's the pump stations. And you see that all the cholera cases, they basically clustered around this pump station, or one of the pump stations in the Broad Street. And it could be shown like that, that actually contaminated water is the origin of this cholera outbreak. So the map was done by John Snow, and it was basically the first epidemiological analysis of the disease, which looked at the disease in relation to environmental risk factors, and it was also the first geographic analysis of disease data. So until today, we use a lot of classical types of studies in epidemiology, so case control study, randomized controlled trials, and cohort studies. So for example, in 1950, Doll and Hill, they tested the association between lung cancer and smoking using a case control design. And in the same year, there was a large field trial conducted on poliomyelitis vaccine in school children. And again, around the same time, in 1955, was a cohort study which was conducted and which exists until today. It's quite famous, the Framingham Heart Study in the US, which really follows longitudinally all the people in Framingham to study kind of risk factors of cardiovascular disease. So to get information on disease-specific data is often very time and resource intensive, in particular for the large randomized controlled trials, but also for cohort studies, where you need to follow patients really over extended time period to look at the outcomes. And it's often more or easier, especially today, to get information, for example, on genetic risk factors or environment, where it's just much easier with the modern methods to get large amounts of data. So epidemiology is very interdisciplinary, as you can see on these slides. So you have basically an interaction between the host, the pathogen, and the environment. And each of these has specific characteristics. And you also have basically different risk factors which interact with each other. So it's really a complex network, and there are also interventions at each of these stages. Now I was also asked to talk a bit about big data and epidemiology. It's not kind of the core thing that we're doing, but I just wanted to highlight some of the examples which are used. I think it has a bit different meaning for people in public health, and all kind of people understand something a bit different among it. But in general, big data is considered to kind of anything that can be processed with a single computer, so that you have really information on a variety of these risk factors, clinical data, patient-level data, that is just too complex to be analyzed with a single computer, and often some machine learning algorithms are used. Just some examples of how these kind of bigger data are used. So, for example, one of them is the wearables, where you can track mobility or the heart rate or also the sleep pattern of persons. So these applications, they are usually focused more on chronic diseases such as cancer, diabetes, or cardiovascular disease. So you can, for example, measure the mobility before or after hospitalization, or before or after surgery. And you can also assess the effect of mobility-related interventions. So, for example, sending daily email reminders and providing some feedback on the mobility pattern to see if the mobility improved. And at the bottom you just see it's a kind of a systematic review which summarizes the use of these wearables. Then, of course, I think we're all aware of the social media. So this is often used to surveillance of public health risks, also for disease outbreaks, and monitor the public health response. So it was extensively used during the COVID pandemic. It can also be used to detect the individual illness for people who are at risk but less motivated to seek diagnosis and treatment. And you can think, for example, about some mental health conditions. Then, quite very well known also, all the more biological data, the omics, molecular biology data. Probably all of us have seen these phylogenetic trees during the COVID pandemic, the different variants emerging. And I think these type of data are most valuable if they can be linked also to the disease progression or the disease risk, which often comes in with some delay. Now I want to talk about a case study from our group where we try to get a better understanding of kind of human behavior and how this influences HIV. Here you see the HIV prevalence in 2020 across many sub-Saharan African countries on the left side, and on the right side between different districts in Malawi, which is also a country in sub-Saharan Africa. And you see how very diverse or heterogeneous HIV prevalence is distributed, not only between countries, but also within countries. And the aim of our research is to get a better understanding of the different factors which may explain this heterogeneity. So here you see just a number of factors which may contribute, for example, the age, if the marital status, economic condition, also HIV knowledge and stigma, but of course also the uptake of intervention. So if someone gets tested in the first place, if they use condoms, or if they use antiretroviral therapy, and the viral load is suppressed and the person is not transmissible anymore as a consequence. So in a first step, we just looked at country-level differences using the demographic health surveys. It's again not kind of a really big data, but it's probably the biggest data set on HIV infection which exists, where in the surveys it's done really in a representative way. It's repeated every 5 years, cross-sectional. And for each of the surveys, you have hundreds or thousands per variables per data sets and thousands to 10,000 individuals in each country. And we used just the most recent survey, which was conducted after 2010 from all the sub-Saharan African countries. So first we just did very descriptive analysis, looking just as the overall proportions or prevalences or so of these different variables across countries. So you see, for example, the proportion of people who are Christians, the proportions of persons or men who had unprotected high-risk sexual contact during their last intercourse, and so on and so forth, so for each of the variables. We then used hierarchical clustering method to determine basically clusters. It looks again a bit like phylogenetic trees, so this time it's socio-behavioral clusters, so that countries which are located close to each other, they're basically most similar in terms of socio-behavioral characteristics. And the numbers of clusters was determined using the silhouette index, which minimizes the distance between points within a cluster and maximizes the distance between clusters. And you see that basically we got 3 clusters out of that. And next we wanted to look at the HIV incidence as determined by a mathematical model by UNAIDS, the Spectrum software, to look how incidence varies between these clusters. And you can see here that indeed there are some differences. So you have there's the Sahel zone here in the north with the lowest HIV incidence, then the central region here and West Africa in the middle, and a very high HIV incidence in Eastern and Southern Africa. So next we wanted to use the individual level data, so not just comparing countries, but seeing if we can use the individual level data to predict the HIV status of an individual. And that's also in the context of these targets of UNAIDS 2030, which stipulate that 95% of people with HIV should know their status. Among those who are HIV positive, 95% should be on antiretroviral therapy, and of those on therapy, 95% should be virologically suppressed. So the first step is really bringing 90% of people into care and testing them. So we focused this analysis on Eastern and Southern Africa, as I mentioned, or we've seen before, with the highest HIV incidence and prevalence. So in this region, we have about 38 million people with HIV, and which represents about 50% of all the people with HIV globally. And it was estimated in 2020 that about 87% of the people with HIV in the region were aware of their status. So finding the remaining 13% becomes, of course, harder and harder, and it's really necessary to develop kind of innovative testing methods to bring additional persons into care. So we used again these demographic health surveys from the 10 countries from Eastern and Southern Africa. And after cleaning, we had information on about 70,000 females and 55,000 males with 122 and 84 variables, and 73 were common to both sexes. Not moving. So we then use different machine learning models that you can see here to compare. So logistic regression, logistic GAM, support vector control, and XGBoost. And as usual, we basically want to minimize an objective function, which consists of a training loss and a regularization term to prevent overfitting. So the model was selected based on this F1 score here, which is just a combination of true and false positive and true and false negative predictions. And based on this score, we selected the XGBoost algorithm, and we could show that using 24 variables for men and 15 variables for women, this algorithm performed best. But if we reduced the number of variables to only 9, which were actually common to both sexes. The prediction accuracy decreased only slightly. So this is asking 9 questions. It's really also possible to use, for example, in a questionnaire. And we are currently testing now this algorithm, or plan to test it in Nigeria to see if we can implement such a questionnaire. So what are these variables? It's the GPS coordinate, it's the age of the person, the lifetime number of sexual partner, if they used a condom as their last sexual intercourse, the age of the most recent partner, some wealth index, and the years lived in the residence. And we wanted to test basically 2 scenarios. So the first one is finding 95% of people who are HIV positive, so the first 95, 95, 95 basically. So the sensitivity is set at 95%, and with that we have a precision, or a positive predictive value, of 23% for women and 15% for men. And this may not seem high, but it's kind of twice as high as compared to general population testing. So if you compare it just to the prevalence in the population, which you can see here. And the second scenario is identifying a high-risk population where the risk of being HIV positive is very high. So traditionally we have risk groups such as female sex workers, intravenous drug users, or men having sex with men. But this time we are looking at more at socio-behavioral risk groups with more than 90% probability of being HIV positive. And we found a risk group basically which consists of 6% of all the women and 5% of all the men, with a precision of 96%. So in conclusion, in the prediction of individual HIV status using more demographic and socio-behavioral characteristics was possible. We could identify the most important risk factors for both sexes and also the direction of association. We only had a small reduction in prediction capability if reduced the number of variables, but unfortunately the algorithm wasn't very well generalizable, so if you want to apply it to a new country, it doesn't work very well, and you have basically to first train it again on similar countries in terms of social behavioral characteristics before you can apply it to a new country. But with that, you're basically able to reduce the number needed to test twofold and identify individuals at high risk. Now I was talking a lot more about quantitative data, but we also wanted to get an overview more of the qualitative literature. And that is actually not an example from HIV, but I think we all know that the number of scientific articles is just exploding over the time. So that's the number of articles in PubMed and for different cardiovascular or other conditions. We've also seen it from COVID. I just read, I think we had now about 4.8 million articles or so indexed in Google Scholars. So when basically getting an understanding of what's being published becomes more difficult. So what we wanted to do next is basically to create some tool which helps us to get a quick overview of the scientific literature and to cluster the articles into topics and subtopics so that we can quickly find some relevant information. So the idea is to automatically download and process open access full text articles, but it can also be done just based on abstracts, and classify scientific articles into similar topics so that then afterwards you can quicker extract relevant information. That's a paper which was published. We are currently working on an extension. So what we are looking at is just that all the literature on HIV in sub-Saharan Africa, so any of these sub-Saharan African countries, and we looked through the several different databases which are here, including also some preprint databases. So by doing the initial search, we identified 137,000 articles We then excluded those who were published before 1986, and those who were not in English. And with that, we wanted to do the clustering. So before doing the clustering, there's some processing of the text is necessary. So for example, doing language checks, but also split the sentences into words, remove some uninformative words, or those who are very frequent or appearing only once, for example, and doing also some spell checking. Then we use this TF-IDF algorithm to basically show that in a matrix form, the information. So we have here in the columns, we have all the different publications. Of course, there are many more. And in the rows, you have the number of words. So it's a vocabulary of about 36,000 words. And to do the clustering based on that is not possible. So we first need to do some dimensionality reductions using the PACMAC algorithm. You see here then on the left side a 2D projection. So each of the points corresponds to one article. And then based on that, we can do the clustering using this HDB scan algorithm, so that each of the clusters now has different colors. Then we can look at the topics by looking at the most frequent keywords in each of the clusters. You can see there's two broad clusters, one on biology, medicine, and one on public health, and with different subtopics and sub-clustering. Overall, we had about 155 clusters, if I remember correctly. And at this time point, the basically human interaction comes in, because you need to select the clusters which are potentially relevant for your topic of interest. So in our case, it was just one topic, topic 9 here. You can also specify additional keywords to refine your search. And often you know of additional publications, which you know from the beginning that they are relevant, and they may not necessarily be in your original corpus. So here we had 23, and actually 7 of them were not part of this original corpus. And then basically you need to go either ideally in duplicate or so through this article and see if they're relevant. And we also started to work with the Citizen Cyber Lab to see if we can use maybe citizen scientists to see which articles are relevant and to extract some relevant information. And basically the same we also used to do some COVID-related literature reviews. So once you have identified your relevant articles, we also wanted to see if we may have missed some additional articles by looking at the closest neighbors. So basically from each of the relevant articles, we selected 10 or 20 closest neighbors to see if they may also have been relevant. And this can be just iterated several times. So at the end, we ended up in this example here with 141 articles, which were relevant to our question of interest. So limitations, it's currently limited to 7 databases. The retrieval of papers is quite time-consuming, so it can take about a week for 100,000 articles. Also, the clustering and the need for hyperparameter optimization is computationally intensive, and the topics may not be relevant, so then you need to look at subtopics, for example. And what we are currently working on is or what we would like to do actually is to have maybe some pre-processed, curated databases on different topics. So it could be COVID or monkeypox or whatever, so that it's updated on a regular basis if new articles come in, and then after a while you would need to redo the clustering, and also building a user interface so that it can be used by non-programmers. Then a third approach that we are using, and we'll be very short on that, is a mathematical model of HIV transmission. So the aim is to construct a model that can take into account the kind of socio-behavioral characteristics and the demographic information and population density in a country, also the sexual contact networks. And then basically it's an individual-based model where each individual is assigned characteristics such as age, sex, the location, the partnership, but also socio-behavioral characteristics and the HIV status, and to basically model the progression of the disease and the transmission of HIV. With that, we were basically able to more or less, without bringing in the socio-behavioral characteristics, the situation of the HIV prevalence in Malawi. So here left we have the data, and the right side is the model in 2010. And then you can see either with or without intervention how the epidemic evolves. So you've seen we use a variety of approaches to really get a better understanding of the human factors that influence HIV and to inform targeted interventions. In reality, kind of screening and linkage to care and also retaining people on antiretroviral therapy remains challenging. Sometimes there's a lack of resources, also of political will. There's a problem with stigma that people don't want to get tested in the first place. And we also seen quite some disruption of services during the pandemic. So there's still a long way to go to reach this target. And of course, we would like to have many more data and kind of be able to link different data sources, bring also in information, for example, on maternity registers or on tuberculosis. And I think there's one success story that I know of is the Western Cape, where they really managed to basically link many different data sources from the hospitals, but also primary care settings, laboratory, pharmacy data, tuberculosis and maternity registers. And South Africa, I think, is also the only country I know of in Southern Africa which has a civil registration and a unique identifier which allows to link these different data sources. So basically the named patient data is separated from the clinical data sources in a separate databases, which is linked by an internal anonymous key. And this key is basically each time differently perturbated for each data sets, which prevents also future cross-linkages. So linkage is important, but unfortunately we often don't have such a unique identifier, or there are ethical and legal restrictions to use such an identifier. So there's one alternative method which has been used, which is the privacy-preserving record linkage. Here is a publication from some of my former colleagues at the University of Bern. So the idea is that basically that you have 3 steps. So there's a pre-processing, the encryption, which is done individually at each of the 2 sites. And then you have the probabilistic record linkage, which is done by an independent and trusted linkage center. You perform a probabilistic linkage with encrypted personal identifiable information, such as name or potentially the full date of birth, and then plain non-sensitive variables. But in other places, data remain often fragmented. There's no such unique identifier, and there is a really decentralization of health system and also the lack of appropriate law, which make implementation of such methods difficult. And often in reality, basic data are not available, or they're available too late and with quite some delay. Because sometimes there's paper-based registers which need to be digitized, aggregated, counted, and so on. And that's often the reality on the ground. And in addition, so I want to conclude with that example. It was during the COVID pandemic, where we were asked by WHO AFRO to support basically the team which was doing analysis on the COVID response for all the 47 member countries, to help them with data analysis and report writing. And since might, Well, that's just basically the number of cases which you see increasing over time. So there was a lot of requests from ministries of health to WHO Afro to help interpret these data and come also to recommendation in terms of what measures to implement. And basically, since WHO Afro was a small team, they contracted a lot of consultants. We were one of them. But of course, my group is also rather small, so I contacted again then a lot of colleagues around the world to help with such a tasks. And you see that the call was quite successful. We also managed to really find quite a lot of people within Africa, so public health experts from there. And at the end, we were over 60 people from 24 countries, consisting from academia, government organizations, but also NGO, to really support that huge amount of work. So the work itself was rather simple. The countries actually shared the data on Excel-based templates with WHO, because not all countries had databases, and this was kind of the common denominator, which was usable for all countries. So we needed to clean these data sets, standardize the analysis, and do also literature searches and exchange with people on the ground to see of what's going on and to make, at the end, some final reports, some weekly and monthly situation reports, and giving recommendations. So the outputs were these reports here in the middle, but we also created some dashboards or slides. Most of the analyses were rather descriptive. We also did some spatial analysis of risk indices of mortality and combined it with external data sources from, for example, Google Mobility. So that's just one of the reports. It was quite extensive, 30 to 40 pages each, with not only the epidemiological situation, but also economic challenges and recommendations at the end. And what we really realized is that there's not enough data scientists on the ground who can help to do this analysis. So basically what is done is the data collection, also the qualitative analysis and the decision, they're all done at country level. But then when it comes to the data management analysis, there's really a lack of enough trained data scientists. And what we're currently working on, also in collaboration with WHO, is to develop, on one hand, a kind of a database which allows us to assemble different databases, to link it also to existing data sources, so both public and private data that allow also to do easy dashboards and visualizations, and to develop some training courses for data analysis in R, which is of course a free software. And the idea is really to increase the use of programmatic data, to have these data much more quicker available, to make recommendations, and importantly also to increase the autonomy of people in countries to do this analysis themselves. So this is, of course, not only useful for COVID and outbreaks, but it should really help to support disease surveillance more generally in these partner countries. So the courses that we are developing is focused on epidemiology. It's multimodal, so we have videos, web quizzes, multilingual. At the moment we start with English, but the idea is to expand also to French and Portuguese. Should be affordable or for free. Have some kind of community features where people can interact with each other. So we had some mentoring system which really helped to scale up initially the whole program, and some progress tracking, which is so far not available in these other existing platforms. So the courses, they should go live hopefully sometime this summer. We have a first set of courses ready now, and we're also looking for other partners who may want to contribute to the development of additional, also more advanced courses. At the moment, it's more introductory courses. Then this data platform, as I mentioned, it should link to existing health information systems such as DHIS2 or GoData, which is very widely used in Africa. It can be installed basically on a cloud or also locally, and it has this FAIN-graded user-based authorization. And you can basically bring in your own data sources, so collect your own data, for example, using Kobo Collect or so, but also use just openly available data sources. And we plan also to go a bit beyond just visualizations and to create some libraries of more advanced analysis which can be used and hopefully help to support the monitoring of diseases in these countries. So with that, I think I'm coming to my last slide. So I think we've seen that it's really complex interactions of different diseases, host, environment, and pathogen. There are many data sources, and they become increasingly available, but they often remain scattered and isolated. So the big data, I think it's specifically challenging to get them on the diseases, less on external risk factors. There remain ethical and legal issues. So this privacy-preserving record linkage may help to overcome some of the challenges. Is, for example, a unique identifier is not available to link different data sources. But we also really need to train people on the ground and basically expand the community and to really strengthen disease forecasting and monitoring globally. Thanks very much.
Thanks so much to Olivia. We welcome questions from the audience. Kate?
Thank you very much. I'm wondering about the scanning of literature. You saw that some papers were not included that may have been relevant. Was there something about those papers? Did they have a different writing style? Were they structured differently? Were they a non-native English speaker? What was it about those papers that they weren't included when you did that scanning of the literature using?
It was other from other databases which we didn't include, which are both, a lot of them were basically from social science databases, and it's not possible to have all the databases or data sources have an API where it's easy to retrieve, and we also didn't have time now to include more databases yet, but yeah, it's a lot of the time was social science papers.
Oh, sorry, so it wasn't that the methodology didn't find the paper, it was just not included in your study, is that right?
Yeah, it was basically not in the original databases which we have included so far. And sometimes it may be gray literature, which is not really in a database.
We have a question online from Alex Pletzer who asks, are you using Kaggle or other platforms that leverage the help of data scientists around the world, or rather are you relying on in-house expertise?
Yeah, so far we relied more on kind of in-house expertise, but reaching out really to colleagues to helping us. But we did have some kind of, also for this Epigraph Hub, we have some open source kind of software developer who is more kind of embedded in this open community, and he reached out to some colleagues. But yeah, I think the aim is to spread more out in the future.
Yeah, very challenging. Other questions from the audience? Yes.
So yeah, thank you for your talk. You showed quite some collaboration with government organizations, but some of these topics should be of interest to private companies as well. Do you have, kind of this private-public partnerships? Companies that come to mind could be Google for, the Google Scholar that could do this literature search, and also health data. They might have definitely an interest.
Yeah, so far we kind of focused, since we also had so little time, we basically focused on public organizations and also help from universities. But I think we'll definitely be interested in the future to work more also with companies. But we did not so far.
I believe I saw a question further back.
But WHO, for them on their side, they do have some of these relationships.
Yes, thank you. A question to the issue of data quality, as in my opinion, every analysis depends strongly on the data quality. How do you manage merging these large variety of different data sources because everything depends on definitions and whatsoever, as we saw during also this pandemic. And how do you reflect that within your analysis?
Yeah, data quality is challenging. So I think with the COVID pandemic, we had the chance in a way that it was really a standardized kind of templates which were provided to all the countries with standardized definitions. But even then, there was big differences between different countries. And what we did is basically to create some data quality report, provide some feedback to the countries and discuss with them how this could be improved. But there was very little time to really interact in depth. So we also do some data collection actually on COVID hospitalized patients in Switzerland. And there we have, of course, a kind of a proper database. We work with the different hospitals. We also provide feedbacks if any data are missing. But yeah, it really depends on the country. And it is time consuming. And if you work with different data sources or which haven't been collected in a standardized way from the beginning, then it's, we did it for HIV, for example. So for example, for the treatment information, you do have more or less standardized types of variables that you can assemble in kind of big cohort or multi-cohort studies. But yeah, it remains a challenge, and you do see differences across sites.
We welcome other questions. Yeah, yes?
Yeah, I'm aware that places like Google, Amazon, they have a huge search databases that can be used to track diseases or the flow or prevalence. Are you in contact with any of those databases, and how might you use those?
No, actually not. It would be interesting to learn more.
Any other questions? Yes.
In research, you like to have all the data that is available, but often for political decision making, you would actually like to focus on the minimal essential data, because this is also all you can collect. Where do you place yourself on that spectrum?
Yeah, I think we often do limit ourselves to kind of the minimum available data which is available across different countries, for example, across different sectors, and even that remains challenging. And then, over time, for example, in the HIV example, we did try to bring in additional data sources, for example, also linkages to cancer registers or tuberculosis or mortality information, for example, to get more detailed information of people lost to follow-up to see if they may have died. So there we worked, for example, in South Africa to use this probabilistic, there was more deterministic linkage, but otherwise probabilistic linkage to complement the information and get more reliable estimates of mortality and loss to follow-up.
Yes.
Okay, just a question about the way you could actually control the system you are analyzing and decision-making to change something to reach a target. Any comment on this?
In what sense?
Well, I guess you would like to change the way things are, and from your data you understand the system, but then you also want to change it to get better health condition, and on which parameter can you act, which is the most effective one to change the situation. I think it's all this theory of control that is actually well known in different contexts, so I was just wondering if you have any idea for that.
Yeah, I think for us really the main challenge was to have more people on the ground who work with data, and to also bring them together to work together across disciplines and across countries. Because what we've seen in this network, it really created quite some enthusiasm and kind of a community spirit, and people wanted to learn from each other. So I think eventually, it should come hopefully with the motivation of people, but then of course also investment in training to really be able to scale up, and this mentoring system was actually quite successful in terms of being able to to scale up.
Any more questions? Right, well, let's thank Olivia again. Wonderful presentation.